All right, maybe I'll just get started. It looks like there's a couple residents on that I could pick on. We're going to try to make this as interactive as possible, just because this is a talk that I gave a couple years ago, and the residents have asked me to give it again to refresh on all the pathologies of anterior skull base and some of the anterior endoscopic approaches. But I definitely wanted this to be a little bit more interactive than our usual morning session. So try to keep everybody's name up here in front of me so I know how to call your name. So we'll go over some of the different pathology, some of the endoscopic approaches, the corridors, the setup in the OR, and then obviously closures for anterior endoscopic approaches to the skull base. So we've now been doing endoscopic approaches for the last 25 years, and they really have allowed us a large access to a large amount of the skull base without these large transfacial and transcranial approaches, which has really changed drastically. I don't think the residents really appreciate it, but when I was a resident, we did like 80% of our pituitaries with the microscope, and a lot of these cases were done open, and it's just how crazy how things have changed in just such a short time period. So when somebody presents with a novel endoscopic tumor, a new anterior skull base tumor, the symptoms are obviously related to where the tumor is and what's compressive. What are the symptoms that it's compressing? So nasal congestion, epistaxis, visual changes, rhinorrhea, headaches, anosmia are kind of the run of the gamut for these. We know that a lot of these cases, and we're going to get into a lot of the pathology and the details of them later on, but we know that they do have malignant cancer of the anterior skull base does has pretty good survival. 50% survival up to 6 to 7 years. And a lot of this has to do with the extent of resection and the ability to get a gross total resection, which is why taking margins and being robust in your approaches is so critical. So I'm just going to get to some of the technical aspects of the surgery and the approaches before we get into the pathology, which is really the meat of the talk. So here, there's a couple different ways you could set up your O-arm for these kinds of cases. You could either do a side-by-side or a cross kind of approach. We do almost all of our cases side-by-side here, just easier with working kind of over hand with your ENT partner. And because of that, all of our equipment tends to go to the top and the anesthesia goes to the bed. A lot of the approaches are done single surgeon, but then we quickly switch to binostril. And I would say that a lot of these cases, not a lot, some of these cases can be done with just ENT, but there's just a lot of advantages to ENT and neurosurgery working together. And I think we see that more and more, even when either our side or their side's part of the surgery becomes minimal. It's just so much easier to work in a binostril approach, to have 4 hands working at the same time rather than just 2. It gives you better field of view, better clearing of the blood, and ensuring that these margins that are so critical are negative. I think out of all the different surgeries that we do, navigation is probably the most important here because, again, we're working in a very hidden corridor where a lot of the anatomy is kind of behind walls of the sinus, behind walls of the anterior skull base, and understanding where the really critical neurovascular structures are so keen. And I think in the future, as we kind of get into this is really where augmented reality, in my eyes, is going to play the biggest role, is these minimally invasive procedures. This is a case from Mount Sinai where they're starting to really kind of develop some of this anterior skull base augmented reality. And you can see here they overlay the augmented reality onto the actual endoscopic screen. So now when you're just looking at the cella, you could actually see the carotids, you could see the optic nerves behind you, and use that kind of Rotanesque X-ray vision that he always has described with anatomy on the screen next to you as you're operating. So what are the different equipment that we use? We have our endoscopes. Typically we use 30 and 0 degrees for a majority of these cases, but we do have the ability to go up to 70 degree. Obviously, you need your endoscopic bipolars. Again, doing a pituitary surgery versus a malignant cancer of the skull base is much, much different. There's much, much more sharp dissection, cautery dividing, and separating in these tumors versus a pituitary adenoma where you're just kind of opening the middle and then just kind of rongering and curetting out a lot of the tumor, and it's not very vascular. A lot of the times the residents, I see them when they use these bipolars, they try to squeeze them shut because it's a trigger handle. That's definitely not the way to kind of use these. You always want to keep them open because there's a lot of cautery that develops on this cauterization that develops at the end of these. It's a different technique than kind of transcranial approaches. You really want to try to look at the layers and be always bipolaring things together rather than just kind of bipolaring just the edges of things. So when you're seeing the dural edge, when you're seeing an artery, you really want to make sure you're wrapped around and you're sealing it together rather than just kind of bipolaring in the dust. So, you know, lumbar drains and CSF drainage is really another area that's kind of changed over the years. I remember when we were first doing endoscopic surgery, anytime you had expected a high flow leak, you'd have a very low threshold to kind of place a lumbar drain. At least that was the teaching when I was a resident, and that has really changed drastically to now we really reserve lumbar drainage to cases where we really feel that there's a low risk of healing or the patient is at high risk for CSF failure. And we've kind of categorized that out nice. So things like a high BMI or somebody who's diabetic or somebody who's a recurrent surgery. These are very kind of far and few between in the cases now. So just having a high flow CSF leak does not indicate needing a lumbar drain. But we still do use fat grafts for some of these larger cases, but not for smaller cases. We switched a lot to AlloDerm. As far as setting up, obviously we have our navigation, we have our scopes. You know, as far as getting access, and I'm going to go through a little bit of this later if we have time, but you really want to have good corridor to the at least to the sphenoid. And the way that our ENT surgeons typically do that is sometimes mobilizing or even removing the middle turbinate on the one side. And then harvesting your septal graft at the beginning of the case and tucking into the nasopharynx, which opens up this corridor to kind of use the binostril approach even further. So the approaches, which I'll show pictures of next, are kind of broken up to these corridors and then approaches. So corridors are kind of what you're going through, and then the approaches are kind of what you end up drilling at the end. We'll kind of go through these here. So we have the transnasal corridor, which is basically what every case starts with. You're going through the nose, and then it's really what sinuses are you going across? So is it transsphenoidal? Is it transethmoidal? Is it kind of going lower, transclival? And then what are you kind of end up drilling off at the end of this? So if you're going really anterior, going transfrontal or across the transfrontal sinus, transcriviform, and then transplanum, transtuberculum, transcellular, and transclival. And each one of these approaches kind of has a different risk profile and also a different pathology of tumor that would typically arise from them and different challenges with the approach. And that's what we're kind of spend a large part of the rest of this talk kind of going through, is what to expect on each one of these areas. So some of the different viewpoints that you would see when you're approaching these access points, you know, the frontal sinus here, we could see kind of going upwards. I don't think any of these videos are going to play. No, they're not playing, unfortunately. More anterior is critical because you need to understand, not necessarily, there's not a lot of neurovascular critical structures in the anterior, the super anterior part of the skull base. But the problem is the repair techniques. And you need to understand when you're going in here how anterior this tumor goes, because what is your repair? The nasoseptal flap is not going to reach all the way this anterior. And so you need to make sure you have a set plan for your repair technique before you start drilling all the way anteriorly to the frontal sinus. As you go transcriviform, you need to start worrying about where the olfactory nerves are. Are you going to be taking one of them? Are you going to be taking both of them? How do you save one of them if you want to? And what are the kind of the very bare limitations to saving the sense of smell going through this area? Transplanum and transsphenoid will get you kind of to the tuberculum and the planum. And here now we're starting to talk about, okay, where is the carotid, where's the optic nerve, and we're going to go through this anatomy in detail as we get to those approaches. So the basic overall oncologic principles for these tumors are that, you know, many of these tumors are growing from the sinuses and the skull base and then erode into the surrounding area rather than directly invade. So it's very rare that you're going to find a tumor that kind of has a finger-like projection going in one direction. They typically kind of just grow out circumferentially and erode the bone and the neural structures. Erosion can be microscopic, and so the important part is we take margins, and I'll give you a lot of data to kind of understand why margins are so critical for these cases. But, you know, just because the bone, your too solid bone doesn't necessarily mean that you've gotten a negative margin. You really need to drill until the bone looks normal. En bloc excisions are preferred, but I think they're pretty rare just because of what the surrounding structures are and the small working space you're working in. However, if you could do an en bloc resection, that's ideal. But the data shows that an en bloc versus piecemeal has not really shown significant amount of seeding or change in overall survival, and therefore is not necessary. And then obviously all these tumors require a lot of collaboration with your partners, ENT, oncology, radiation oncology, and the oncology teams are both medical, neuro-oncology, and head and neck oncology, which is sometimes confusing, but it's important to include everybody. Okay, so let's get to some of the different pathology that we expected to see in these areas. These kind of break down some of the major ones that we're going to talk about. Squamous cell sarcoma, adenocarcinoma, esthesio, and then this miscellaneous kind of group. And that's actually a number. So in my first 4 years, I've kind of done 70 of these anterior skull-based cases. Now it's kind of doubled in size. When I think about these pathologies, though, I try to group them because some of them are pretty obscure and rare. And so I like to group them into kind of major categories, and that kind of helps me understand what are the different differentials that could be. So we have neuroendocrine sinonasal malignancies, which really originate from the epithelium and the paranasal sinuses. And then we have the non-neuroendocrine ones. And these are things like nasopharyngeal carcinomas, adenoid cystic carcinoma, squamous cell, and primary sinus tumors like adenocarcinoma and sarcomas. And then we have our rare but more aggressive types of benign intracranial pathologies. So atypical malignant meningiomas that kind of cross over the skull base, or a pituitary carcinoma arising in the sella, but then eroding down into the anterior skull base. And then we have some more of our benign pathology, which is that typically behaves more malignantly because they typically recur quite frequently. So things like craniopharyngioma, chordoma, chondrosarcoma, or juvenile nasopharyngeal angiofibroma. And this is just another way of breaking it down. So we're going to go through these different pathologies as we go through different areas of the skull base. So we're going to start really anteriorly and then kind of go down the skull base. So we start transcribiform, which is the most anterior. And some of the pathologies here are things like esthesioneuroblastoma, SNUC, adenocystic carcinoma, and squamous cell carcinoma. Let's see if any of these are going to work. No. So 30-degree endoscope is really critical for using this. We want to open up the frontal edge of the sinus to get really anterior, the most anterior exposure here. You can obviously see this is the angle of view, but you're coming in through the nose. And so you need this either 70-degree or 30-degree scope to kind of see around this corner to see up the frontal sinus. Yeah, sorry about the videos. And you want to kind of complete what's called a typical anterior skull base resection. And you could either do this a bilateral or unilateral, depending upon where the pathology is. And much of this is kind of performed by our ENT colleagues, but then we're called in to kind of complete this by getting exposure to the dura. So you need to understand kind of what your landmarks are, and then open the sinus, sending margins, and performing the skull base. So we're going to go through the different steps here just for the residents. Basically, you want to start. A lot of this is done by ENT, but I think it's so critical for us to understand kind of what their steps are and how we could help them. And obviously, just to how to cover these cases in case they get called to another room, it's important for us to kind of be able to kind of complete all of the components of their exposure. So identifying the posterior frontal wall of the sinus by opening up the nasofrontal ducts is kind of referred to as this Lothrop approach. And as we go more superior, we're defining the crystal galley, which is here, and then the anterior curviform plate. After we open this up, we basically are going to send, the ENTs typically by this point send margins of all the sinuses in this area, and then we decide on exactly, we're looking at the anterior skull base bone here. What is the extent of the bony kind of cuts going to be in order to ensure that you have negative margins based on what the sinus margins are. We have to understand where the anterior and posterior ethmoidal arteries. Typically, the anterior ethmoidal arteries are going to be about 18 millimeters back from the anterior of the skull backwards. And so you can see one here, and then another about 18 to 25 millimeters beyond that one is going to be where the posterior ethmoidal arteries are going to be. And you need to understand those because in tumor cases, these will tend to be quite large, and it's better to kind of drill them out and cauterize them rather than just drill through them, and being prepared to understand how to take them with either the monopolar or the bipolar is critical to kind of make things a little bit less bloody. We want to complete our total ethmoidectomy, so to find our orbits and to find our anterior and posterior borders of the ethmoid, and then complete the 6 bony cuts, which are basically going to be the coronal, basically the anterior coronal, posterior coronal. This is kind of where your planum is here. This is the anterior where the frontal sinus is. Then you're going to do your 2 sagittal cuts here, and many times we'll be called in to do this, and so it's important to understand how to kind of complete these. So we're going on both sides of the cribriform plate here, and then finally we need to kind of detach. We have the crista galli, and which is in every case slightly differently kind of calcified. So understanding how to disconnect the crista galli from the falx and then cut this kind of bony aspect off of the falx is kind of the last step that becomes a little bit challenging, just because you're working really anterior and the instruments are very minimal that could kind of make those cuts in those drills. So using a frontal sinus drill, which is a very curved 70-degree or 90-degree drill to kind of make these cuts and open up the anterior frontal bone. So at the end, it's going to basically look like this. You're going to have kind of your bony cuts made, your dura opening made. You've kind of made the 4 cuts of the dura, and then also divided the dura from the falx along the entire falx. You're watching out for your orbital frontal arteries and also your ethmoidal arteries on both sides. And then we'll send our frozens from all of these different areas, dura, brain, falx, to make sure we have clean landmarks. So let's go into the pathology here. Let's see. Yeah, we wanted to ask, let's see, one of the residents here, let's see, Damien, are you on?
Yeah.
So kind of why don't you describe kind of some of the characteristics of this contrast enhancing MR and kind of the different pathology that I've named so far. Give us your best guess here of what you think this is.
Sure. So it looks like a contrast enhancing lesion, predominantly within the nasopharynx, with some extension superiorly along kind of the anterior cranial fossa floor, but doesn't really look like it's invading much intracranially.
Right. So you're kind of so where do you think it's arising from?
The nasopharynx, not intracranial pathology.
Right. And the fact that it's kind of also spread out and touching a lot of the different sinuses, also indicates that it's most likely a malignant. And so how would you, what are the kind of the steps before surgery that you would want to know before you kind of get in there? Would you just book this case for this afternoon after seeing this MRI, or no?
No. I mean, you'd want to see if the patient has any, history of other cancers or, previous tumors in the area. But given the, accessibility through the nose, probably doing, having ENT biopsy it, so kind of a sample, in a ER or wherever, to give a kind of quick, idea of what it might be, because that'll guide resection versus adjuvant therapy.
Yeah, exactly. I think, in many of these cases, we end up starting with biopsies because you want to understand what the pathology is, and then what are your options. We're moving more and more towards this neoadjuvant therapy, which is really kind of the data that I want to share today. So this ended up being a SNUC, which is a sinonasal undifferentiated carcinoma. And there is now data that shows that induction chemotherapy for these patients is one available kind of treatment. And so the question is, when do you decide to do preoperative chemotherapy and when do you not? And this is the data that we try to do a kind of a literature search. And I want to thank the fellows for really looking at this over the last couple of weeks, because it's still kind of unclear as to who benefits long-term from induction chemotherapy and who doesn't. But basically, for sinonasal carcinoma, at this time, all patients will undergo induction chemotherapy unless it's a small, very well circumscribed lesion that you could get without concern. And the advantage is that you can already kind of understand which tumors are kind of responding well to the chemotherapy and which ones not. And so some of them respond exceptionally well, and then you end up not needing to do a complete resection. But in this case, you could see that the tumor is kind of involving both medial aspects of the orbit. And so in possibly even going into the periorbita fat bilaterally. And so when you're operating, the last thing you want to be doing is kind of going into the orbits bilaterally, because you could have a high morbidity of having diplopia and issues with this. And so if you could get this to retract a little bit off of either one or both orbits, that will kind of allow you to be more aggressive with ensuring your margins are negative. And so this idea of induction chemotherapy for a lot of these tumors, you'll see is really what's changed over the last 10 years. And so this is kind of one of the paradigms that was just published in the JNO in 2020, showing that we do induction chemotherapy for SNUCs. And if they have a great response, then they kind of just on-go and continue towards chemoradiation. If the disease has minimal response or if it's very resectable, then we'll go on to surgical resection, or if it's not resectable, then continue to on-go to chemoradiation. Radiation is typically with IMRT with 60 gray, and then obviously you want to understand if there's any spread of disease and radiation to other areas are needed. These are some of the kind of pathology characteristics of this tumor. You can see very high mitotic activity. It's positive for cytokeratin stain, and they do have IDH2 and IDH1 mutations in 80% of cases. And these are just some of the other recent literature that have been published by both the Ohio State Group and MD Anderson, again, talking about what are their paradigms for understanding when to resect and when to do just radiation. And so the Ohio State one was actually really interesting. They have a lot more details. So basically MRI and PET scans to assess disease extent, to understand if there's any lymph node positivity in the neck. And then you go on to induction chemotherapy. If there's no vision loss, obviously if their patient's having acute neurological changes like vision loss, you would undergo decompression first, and then undergo treatment, and then eventually follow this with MRI and PET CTs. Okay, so this is the next case. Let's see. Maybe Kat, or no, Davik, are you there? How about Mari?
Hey, Dr. Ivan, I'm here.
Oh, perfect. Yeah. So, so again, another contrast-enhancing lesion in the anterior skull base. Maybe describe how this one's a little bit different than the last one, and what are your differential?
Yeah, so you have an enhancing lesion here that's extending from the anterior skull base down into the sphere of the ectoid sinuses here. It's a little more distinct than the prior, and so it's pretty well circumscribed. Does not look as aggressive in its invasion. I'd say my differential for someone would expect something like sinonasal carcinoma, like a primary sinonasal carcinoma versus anesthesia.
Yeah, I mean, again, you're trying to understand where do you think this is arising from. So, you could see here that it's much more midline and much more kind of involving the cribriform plates and probably the olfactory nerves. And so, more midline and involving this kind of curviform area, what would that make you lead towards another possibility? Oh, I think we lost them. So esthesioneuroblastoma would be kind of the top, a little bit more higher on the list for me for this case, just because it arises from the olfactory neuroepithelium in this case, and because it's so midline and really kind of that center point of where the growth point is kind of centers around that. It could be, although again, all differentials are possible in this case. I wouldn't say that's definitely the only differential. Esthesioneuroblastoma are kind of a bimodal distribution, or kind of a unimodal distribution. Most of them are 60, very small peak in the 20s, mostly 40 to 70s based on the SEER database. Again, there's two different kind of classification systems. There's the modified Kaddish classification of 93, which talks about kind of just how invasive the tumors are. And that correlates to basically what their overall survival would be. And so you can see here, tumors confined to the nasal cavity or have a very good survival. And tumors that kind of extend beyond the nasal cavity, like this one, where it's extending into the anterior fossa in the brain, 5-year survival goes down. And then tumor with metastasis that goes beyond the cervical lymph nodes obviously have the worst kind of survival. And then there's a histological grading system as well that kind of talks about the extent of pleomorphism and different kinds of rosettes that you could see, as well as the amount of necrosis and mitotic index that you could see in them. And it's also kind of correlated to overall survival. So here are some kind of key aspects: uniform blue small cells in the pathology. 30% of them have these Homer-Wright rosettes. We can see here identified carefully. And then, the Ki-67 could really be quite expansive, from 10 to 50%. More aggressive types have more of these deletions of chromosome 10 and a gain of 1p. We have looked at the grading scale and overall survival. So based on the pathology grading scale, you can see here very obviously that there's a significant difference in the overall survivability. And this is without looking at extent of resection. And again, we're seeing here this kind of development of the induction chemotherapy for these cases when they present with a lot of invasion. And so for the Kaddish C and Ds is really talking about preoperative chemoradiation before you resect to see if perhaps the tumor will respond and shrink into areas where you could have a more thorough and ability to get these negative margins, because it does make a difference in these cases. And if you can, then you could kind of devise your approach to maximize the extent of resection to minimize your recurrence. Okay, so this is another case. Again, you'd say, okay, well, this is really not even involving the anterior skull base, but this is not the best picture, unfortunately. This is tumor here in the right kind of nasal area involving kind of the maxillary and sphenoid sinuses, but it actually goes back up to the skull base here, involving where we, V2 would be coming out. And that's why we were involved in this case. Patient presented with tooth and facial numbness. This ended up being an adenoid cystic carcinoma that we resected, started in the maxillary sinus, invaded into the neural foramina, and extended into V2 and V3. We do take margins along these nerves as you transect backwards to try to get a negative margins on the nerves, but eventually, as you get to intradurally, you can't kind of continue along the nerve resection due to the extent of kind of how much perineural invasion there is. So if there is perineural invasion, obviously there's a high risk that it's along the entire nerve, but when you're at the nerve, you still try to get a negative margin. Obviously the goal of surgeon is to resect as much as possible without compromising the orbital cranial nerves. I would say that V2 is kind of the exception to the rule there. It's minimal kind of function in your V2, and that nerve we take without really too much concern. Post-op radiation for these tumors tend to be more beneficial than chemotherapy, and the overall survival about 75% at 5 years. As far as a neoadjuvant therapy for these tumors, again, this has been induced, and this was actually an interesting study by our own Dr. C in our ophthalmology department, where they were looking at adenocystic carcinoma in the lacrimal gland, and they showed that if they give cytoreductive chemotherapy pre-surgery into the lacrimal artery, they actually were doing a much better job with controlling survival than without. With the ability that with the patients that it responded with. So I think, again, you're seeing this theme with a lot of these tumors, is this ability to do neoadjuvant chemotherapy radiation, which is something we need to think about when these patients kind of present in the ED, and we kind of sometimes jump to the gun of surgery. There's also different histopathologies with adenocystic carcinoma. There's a solid pattern and kind of a non-solid kind of patterns within the actual tumor, and that actually ends up playing a major difference in what their overall survival is, as well as their mitotic index, which is not surprising. I'm going to skip that. Okay, this is another patient, 42-year-old gentleman. You can see much more extensive kind of intracranial invasion with this tumor. And this ended up being a squamous cell carcinoma. Sorry for the spelling issue there. But again, neoadjuvant therapy is becoming a critical component for squamous cell carcinoma of the skull base, with a platinum-based and taxane-based regimen. 2-year survivals are a little bit worse for this disease, 77% versus 36% in patients that don't show response to chemotherapy. And so will that end up telling us how aggressive to be during surgery? Do you be more aggressive or less aggressive if the patient is not responding to chemotherapy is kind of up for debate. Neoadjuvant intraarterial chemotherapy to the maxillary artery is also, there's a few studies that have shown that this has been effective. It's not really the mainstay treatment just yet, but it is an option. And then chemo and radiation neoadjuvant has also been looked at, as well as doing 50 gray and 25 fractions with chemotherapy, and was found to increase the rate of clear margins in the tumor site and allow for more of negative margins and overall better survival. So here's another paradigm that kind of looks at when to do which approach. This is out of MD Anderson. So again, if there's intracranial involvement, and if the facial skin, nasal bones, or frontal bone are involved, then likely you're going to be doing more of a transcranial, transfacial approach, where if that wasn't involved, you could get it endoscopically. Pathology, 50% of the cells are keratinizing. They have these irregular nests and cords of eosinophilic cells. And the non-keratinizing types have this ribbon-like growth pattern with absent and limited maturation. 20 to 25% of squamous cells are HPV positive, which maybe that'll become important in the future for some of these oncolytic trials and targeted therapy. Other prognostic biomarkers for squamous cell are listed here, and are all kind of critical for understanding not only their prognosis, but also response to chemotherapy. That being said, patients that have intracranial extension tend to do much worse. And so we see here that when a brain is involved with these patients, their overall survival is dramatically less, with a 50% survival, less, just around 2 years, a little bit less than 2 years. And so that is critical to understand how aggressive to be with these patients when you see extensive intracranial and brain invasion. That being said, gross total resection, if you get negative margins, which doesn't count brain margins because it's very difficult to understand what the brain margins are, but say it's not involving the brain and you get negative margins, does play a major impact in survival, which is why understanding, the anatomy, understanding if you could kind of get some partial response and some shrinkage before surgery would play a major importance in deciding how to treat these patients. Okay, so let's kind of continue our journey backwards to transplantum and transtuberculum. Our pathology is now a little bit more relatable to what we've done in the past. So we have meningiomas, craniopharyngiomas. In this area, this is a patient, 35-year-old gentleman who presents with headaches. And this is kind of what the MRI looks like. Let's look at, let's see who, maybe Kat, are you on? Dr. Barry?
Yeah, I'm here.
Yeah, so what is your, tell us, obviously we know this is a meningioma, what are your approach considerations for resection of this tumor?
Well, it looks like it's coming from the cribriform plate, and to get a complete resection and control of the blood vessels or blood supply, you're going to have to get very low anteriorly. So a lot of people would probably do a bicoronal approach for this, but you could try unilateral frontal craniotomy. I think bicoronal.
Yeah. So good. I mean, I think a transcranial approach, I mean, obviously, endoscopically, this comes way out lateral, which is less than ideal. It's also involving kind of the superior orbit bilaterally. But there is a large amount of kind of bone. You can see it here on the sagittal scan. It's eroding through the anterior skull base and going down into the ethmoids. This is actually done by Dr. Komatar. It came in actually very close to where the tumor came to the surface and did a unilateral approach and resected this. And unfortunately, the pathology came back as grade 2, and there was this component that was still left in the ethmoid sinus. And so we went back endoscopically, and I resected this part here just because he was so young and it was grade 2 to get a complete resection. But that bring up another concern is that, what are your concerns with an endoscopic approach here for the repair techniques?
You can have a lot of issues with CSF leak, of course, because you've taken the dura on the skull base. And then, you can have mucoceles or communication between the sinuses. So you just need to make a really good repair at the end of the case.
Yeah, I mean, not too much mucoceles, because you're definitely gonna be stripping, like you said, the dura and the mucosa off of this while you're doing a resection. But what's different here is that there's a huge resection cavity because this tumor was just extremely large. And so typically what you want is, as you pack from below, you're expecting that the brain will fall down and kind of seal from above. And the combination of the two is what calls that kind of watertight gasket seal. But in this case, there's obviously no falling down of the brain because there's nothing up there. And so the question is, what are your repair techniques available for this case?
You can do a fat graft with like a nasoseptal flap. You can do alloderm, but I don't think that's probably sufficient here.
Yeah, I agree. So we ended up doing a large fat graft and a large nasoseptal flap, and that held well in him. The alternative is, if you're transcranial looking at this, you could do a large pericranial flap and just repair it from above. I think this is a video here of showing. I'll just kind of go to where we were. This is the removal of the tumor. And you can see automatically you're seeing through this bone here, and this is the large opening into the anterior, the frontal lobes, where the large defect of the meningioma was, and just kind of drilling out this tumor completely, and the anterior skull base. And then at the end, you kind of, this is right before the end. Yeah, this is basically looking up into that large cavity here with the entire defect. And so we had to put a large piece of fat there, larger than normal, in order to kind of keep that recorded. Then alloderm, and then a nasoseptal flap. So we used kind of all 3 tricks in the book for the repair. So again, limitations to endoscopic approaches for interskull-based meningiomas is a whole nother talk that we could spend an hour discussing. So I'm not going to really go into that here, but just to kind of touch on it briefly, obviously going lateral to the optic nerves or being involved in the superior lateral optic canal is in kind of a no-go. Tumors that go too far forward, so involving kind of the posterior wall or the frontal sinus, you have to be very careful on again, what your repair techniques are going to be in this area. It may be better to use a pericranial flap. And then vessel encasement. So here you can see meningioma. It's very clearly involving the ACOM and the A1 on the right, and things that you would not want to be pulling on from below without having good control of those vessels. So here's another case, a 29-year-old with bitemporal vision loss. Let's see, let's go up the chain to Alexis. What's on your differential here? Dr. Morel, are you available to talk? No. Okay. How about Tyler?
Yeah, Dr. Ivan, I'm here.
Oh, great. Yeah. So what is your differential for this?
Sorry?
What's your differential here?
Oh, in the cella could be pituitary adenoma versus craniopharyngioma. Oh, sorry. It's the echo.
Yeah, good.
You guys hear the echo? Rathke's class 6. Thanks, Adam.
Great job. Yeah, so for this case, because you could see this cystic kind of involvement of the tumor, you'd say much more likely to be something like craniopharyngioma. Pituitary adenomas are typically homogeneous, and if they have a cyst, it's typically just one cyst, not multiple lobulated cysts here. So that kind of gives it away a little bit. And additionally, you can kind of see the gland is being pushed down here. Interestingly, the cella is expanded, which is not typical for a craniopharyngioma, but it is possible. And you can see here. So again, transplanum, transtuberculum approach or transcellular. You can start transcellular here, but typically you really need to see above the capsule of these tumors to kind of understand where the pituitary stalk is on the posterior aspect. And so a tuberculum approach would be much more helpful in this case. So removing the tuberculum involves obviously the drilling, but then you need to identify where the superior intracavernous sinus is and cauterize and divide that. And then that will just give you a much better view of that capsule superiorly. So when you debulk and you pull it down, you can actually see where the pituitary stalk is going behind the tumor to try to preserve that the best you possibly can. And so this is, our typical cellular approach would be just kind of down here where the suction is, where we do our cruciate approach. Here we can see we drilled off the tuberculum and a little bit of the planum in order to kind of see where this crease is. Here is where the sinus is going to be. And so you typically want to open the dura above and below, and then cauterize both sides of it and divide it in order to give you that transtubercular approach. When you get in there, you have this kind of viewpoint. Obviously, the tumor will be in your way, but after the tumor is resolved, you'll have this view, which will kind of, you're staring here at the inferior and superior hypophyseal arteries. You could typically take the inferior hypophyseal arteries without too much concern, but superior ones you try to preserve. So when we look at the comparison for tumor control, for craniopharyngiomas, again, we see gross total resection is key. However, subtotal resection with radiation was actually in many cases was very similar to a gross total resection. When we looked at the Sears database to kind of look at this kind of transition of transcranial to endoscopic approaches for craniopharyngiomas, and we found that in these cases, which was 11,000 patients from 98 to I think 2015, was many of the cases did much better with endoscopic approaches, but I think a lot of that was, I think there's many reasons for that. A lot of it is because you're kind of approaching these tumors in a much better direction, and so you can preserve the pituitary stalk, and also you can decompress the optic nerves earlier. But also, some of the more challenging tumors are reserved for transcranial approach. So tumors that have vessel encasement, go out lateral, they're just extremely large, tends to still be transcranial. But that being said, I still think there's data that can be elicited from this. Length of stay, overall discharge disposition was all better in the endoscopic approaches. Death, diabetes, CSF leak, even in a multivariate analysis, all these ended up coming out as significantly better in the endoscopic approaches, and all complications were also better. Now, again, a lot of that is due to, obviously we don't have the radiographic findings in a SEER database search, but I think that trend is important to realize that we should be doing more of these endoscopically if possible. That being said, there are some that you just can't do endoscopically. So here is an interesting case of a ventricular craniopharyngioma. Again, that's on the superior pituitary stalk here. Obviously not a good choice for endoscopic approach here because the corridor is potentially very, very small, and this tumor is very, very solid by the fact that it's all enhancing. And so, you know, an intrahemispheric approach or some kind of transventricular approach to this would be kind of the way of approaching it. Here's another example of a very lateral kind of craniopharyngioma with a cystic component going out well into the right temporal lobe along the MCA and along the vessels. Here you're worried about the PCOM on the medial aspect of it, and the MCA and the kind of the lenticular striates off of the MCA as well. So a transcranial approach, obviously important. This is one other consideration. This is a tumor. It's very hard to see in this picture, but the carotid to carotid width is less than 1 centimeter in this patient. And so for dealing with a tumor with a significant solid component like this one, you need to be concerned that, you know, if you're going to need to get the sonopet up there in order to debulk this, is it going to even fit through that window? And so to make this window wider, typically you could go more of a transtubercular approach and then transpose the gland to one side to really get beyond it, which can increase your risk for hypopituitarism. This is our case yesterday. It's also a very strange craniopharyngioma with significant inferior extension as well, superior and lateral extension, obviously significantly recurrent with a small, just solid component here in the sella. Goal of care here was really to try to remove as much of the solid component and decompress the cyst, knowing that already when these tumors become recurrent, the second and third stage surgeries end up having a much, much higher morbidity due to the fact that these cyst walls tend to now encase and erode into the vessels and attach to the peel surface of the brainstem. And it's unlikely you're going to be able to get a complete cyst removal in a case like this. Here's another case that we did a couple years ago. This is like 8 to 7 years ago. It's a very, very solid craniopharyngioma in a nurse. And again, the concern here was that there is so much solid components, and on the CT, a lot of this was calcified. And so I think today I probably would have done this endoscopically and tried, but early on we did this with the bicoronal approach to remove that all. And this is the post-op scan here. She ended up doing well. This is actually her 5-year post-op scan here on the right. So again, it's this consistency in how much calcifications also play an important factor as to how much, what your approach is going to be. Okay, lastly, well, the second to last transcellular approaches, again, pathologies include Rathke's cleft cysts and pituitary tumors. And obviously, we need to kind of really understand what the extent of these tumors are. We're going to go through this kind of approach. I'm going to skip through this because we're running out of time, but for the exposure for these cases. But just going over some of the anatomy here for the residents while we're doing pituitaries, when you're looking, when ENT calls you in and you have access to the sphenoid sinus here, you know, we could really use our anatomy of the bony inflections here to understand where the carotid carotid protuberances and the optic protuberance and where the OCR is on both sides, and understand exactly where we need to be and where we need to avoid. And so it's almost in I'd say 95% of the cases, this bony anatomy is enough to kind of guide you towards the midline. In very few cases is the kind of the navigation needed to kind of understand exactly where the midline is. So you should really understand kind of where these different components are. And understand when you're looking at the bone like this above, exactly what is beneath it. And these are just some great pictures from Roten. I'm going to skip over in lieu of time here. So the question is then, when do we need to kind of get into the cavernous sinus for these cellular lesions? I think there's been some documentation that obviously if it's a high-grade pituitary tumor, it's more helpful. And additionally, in functional pituitary tumors, where you're really trying to get a clear functional response, and the tumor is invading into the cavernous sinus wall, not located purely in the gland, Juan Fernandez has shown nicely in his data that taking the medial cavernous sinus wall definitely helps with the control rate of the functional hormone secretion in those select types of tumors. There's two ways to kind of go about that, is when you have visualization as a contralateral standard approach, or kind of this far lateral approach. And this far lateral approach is a little bit more off center. You're taking down kind of into the maxillary sinus here on the lateral aspect. And this is really only used for tumors that kind of extend well beyond the cavernous sinus into the temporal lobe, or around involving the entire cavernous sinus, for chordoma or pituitary tumor that may be resistant to therapy that you're now trying to get a more aggressive resection on. And when you do that, you need to understand in the cavernous sinus, what is the critical anatomy? And the most important thing is this carotidoclinoid ligament, which is the most anterior ligament. But if you're going to be taking down the posterior clinoid and really mobilizing the pituitary gland to the side, as we talked to before, for either like a craniopharyngioma that's behind the gland, you need to understand all of the different ligaments, so the inferior paracellular ligament, the superior paracellular ligament, and the interclinoidal ligament. And so these ligaments need to be kind of separated and divided, typically closer to the pituitary gland than closer to the carotid, and that will gain access to the posterior clinoid. And you could do this by only entering into the sellar space, or even just into the cavernous sinus space, not even into the sella. And so you're really extradural doing these ligament takedown in order to mobilize the posterior clinoid. Okay, lastly, we'll go back to transclival approaches where we have chordomas and lymphomas. This is an interesting case that I thought was a meningioma early on in my career, but in retrospect, it wasn't. A 30-year-old gentleman who presented with 600 palsy. You could see kind of what the tumor looks like here. And what gave it away postoperatively was the fact that the posterior clinoids were eroded and free floating, which would not have happened in a meningioma. In a meningioma, you would expected hyperestosis in this area, not erosion. And so, we did a transcranial approach and found out that this was a chordoma. And then we had this residual down low on the clivus that we then went back on and did a transclival approach, which ended up working really well. And he then went on to get proton beam, and this is his 5-year post-op scan showing no recurrence. So chordomas could sometimes be a little bit elusive, but they do present from the fetal cartilage to the nodal cord, which is involved in the skull base, and give rise to their counterpoints, such as chondrosarcomas and chordomas. Just trying to get through some of this real quickly. I'm not going to go through this. So, we treat all of these patients with proton beam. This is a study out of Boston showing Gazzea. They're actually, I think, the oldest proton beam center in the country since 1978. So they have the longest long-term data. You can see that chordomas, which are in red, do much worse than chondrosarcomas, which is why we really focus on trying to get a gross total resection of chordomas much more. And then they all get radiated postoperatively. When we looked at, this is one of our fellows, Dr. Zanonos, who's now at Pittsburgh, has several great papers on kind of the molecular prognostication of clavochordomas. And what he kind of was able to do molecularly is divide chordomas into 3 major molecular groups and show that without looking at even the extent of resection, group A tumors do much, much better than B and C's. And what those group kind of break down to is this 1p36 deletion and 9p21. And if you ask our neuropathologists here to run these tests, they actually will do that for you and tell you exactly what group your chordoma looks into. And so far, it's been really well validated to what George has published in multiple papers thus far. So in the last 5 minutes, I'm just going to touch base really quickly on closure. Typically, what we do for our closures is, we put Certicell along whatever brain or sella that we have exposed. We then place Alloderm, which is then kind of packed into place with a little bit of Certicell and gel foam, and then a septal flap, nasal septal flap on top of that. Again, lumbar drains are reserved for patients that really have high risk factors, and then our postoperative care. And then we place gel foam and then Mearcel packing on top of that. No positive pressure for at least 3 days. I'm not going to skip over exactly how to do a nasal septal flap. Again, when you have very large exposures, like this is a case that we did 3 weeks ago, is a large esthesioneuroblastoma with Dr. Levine, and immediately we knew that this was much too large of an anterior skull base defect to just close from below, and so we were prepared for that. And we did a bicoronal craniotomy at the same time as our endoscopic approach, and then laid down a very large pericranial flap, which held well. And this is what our postoperative kind of closure looks like. This is a large nasal septal flap, which is able to cover the back. And you can see here nicely, the nasal flap really, in this case, only came up to almost the midplane, maybe posterior cribriform, but all of this anterior stuff is really just being closed by the pericranial flap in front. And we actually sutured that down in this case to the dura to make sure there's a watertight seal. And I'll skip and this is really helpful actually for the residents. So just kind of a video showing exactly how to raise a pericranial flap. You can't see it, I'm gonna skip it. So risk factors for postoperative CSF leaks. We looked at this when I was a resident, and the most important thing in our experience was BMI for predicting CSF leaks by far. And we did a multivariate analysis here, which showed that abnormal BMI in complex anterior skull-based cases was the most important predictor of a CSF leak. So I think in those cases, I now place lumbar drains. As far as infection goes, interestingly, hypertension and cardiac disease was actually the most important, and diabetes was trending towards important, including BMI. So overall, that's kind of a run through of what these pathologies and what the approaches are. I think the endoscopic surgery is definitely the way to tackle these tumors, and the morbidity and mortality has really been decreased because of this approach. We went over the 5 different kinds of midline approaches, as well as the corridors, and also what is the role for neoadjuvant and post-adjuvant treatment for some of the most common malignancies of the anterior skull base. And obviously, I just want to thank all of our ENT colleagues, Dr. Levine, Dr. Sargi, Cassiano, for all of their help with these cases, and then also all of our fellows who helped me put this grand rounds together, Martin, Alexis, Kat, and Lekraj. Thanks so much. Any questions?
All right, so good morning, everyone. It's an honor to present cerebral bypass to you all. It's a very important topic, and honestly, it's a topic I'm passionate about. That's why I wanted to present that today in front of you. So this topic is more of an overview of cerebral bypass that, I would cover the history of bypass, the current indications of bypass, and then we would go into the bypass techniques. Then we will cover, the choice of graft, the direct bypass types, the blood flow types, which is a bit controversial topic, interposition grafts, anastomosis types, and then finally, we would just go into more of how to start your suturing techniques in different types of bypasses. So going back to the ancient Egyptian civilization, almost 3000 BC, a book called Eber's Papyrus, which is an ancient Egyptian medicine book that describes all the ancient Egyptian medicine at that time. So they describe blood vessels as met. And aneurysms at that time, surprisingly, was treated with heated instruments. Now, in 4th century BC, we know that Hippocrates described the various hemostatic techniques from his animal dissections and his limb dissections from the animals. Then the father of anatomy, Herophilus, which we all know, the Torcula Herophili, described by him. He described the skull-based vessels, I hope I pronounce it right, as ready mirable, meaning that this is a wonderful net. And afterwards, the famous Greek anatomist and surgeon, Galen, also known as Claudius Galenus, he described the cerebral vasculature, cranial nerves, in the venous sinuses. And we all know the famous vessel, the vein of Galen, described by him. Now, going to the 2nd century, we know that Antyllus, another Greek anatomist and surgeon, he actually described his aneurysm treatment with proximal and distal ligation, followed by a thrombectomy. And then almost 1,000 years later, an Arabian anatomist and surgeon, Albucasis, he was the first to dissect and ligate the STA for headaches at that time. So this actually paved the way for future dissections of blood vessels and vascularized pedicles. Then another anatomist and surgeon, André Vesalius from the Netherlands, also, he actually corrected almost 200 anatomic errors by Galen in his famous book, De Humani Corporis Fabrica Libri Septem, which means the fabric of the human body in 7 books. Now, Nikolai Eck is a Russian military surgeon. And at that time, he actually described the Eck fistula. Basically, the Eck fistula is where he ligates the intestinal venous drainage from the portal venous system, and then he anastomosed that to the inferior vena cava. A famous French surgeon, Alexis Carrel, was actually awarded the Nobel Prize in 1912 for his end-to-end bypass description. So he was actually one of the first to perform an end-to-end bypass. Michael DeBakey was known for his carotid endarterectomy in the 1950s. And we know that Lyons and Galbraith, so Lyons is a general surgeon and Galbraith is a neurosurgeon, both are at the University of Alabama. They were the first to perform a subclavian to an ICA bypass using a nylon sheath. Now, Yazargil was actually the first to perform an end-to-side anastomosis using the STA in 1967. His first patient was a Marfan syndrome patient with Moyamoya syndrome. And from 1974 to 1980, Spetzler has contributed greatly to the field with, he utilized the occipital artery as an alternative to the STA. He also studied the graft flow, and he also performed an extracranial to intracranial bypass for intracranial aneurysms. In 1978, Osman utilized the radial artery graft for his ECIC bypass. And the same year, we know that Throughout Sunt performed the occipital artery to pica bypass. Now, going to a different route, the indications of cerebral bypass is pretty limited, but it mainly comes down to flow augmentation and flow preservation. So flow augmentation is needed in diseases where you have ischemic symptoms such as Moyamoya vasculopathy or atherosclerosis. However, flow preservation, you need immediate flow to avoid any stroke. And this is needed mainly in aneurysm bypass or the less common skull-based surgery tumor bypass. And as mentioned before, bypass indications have declined in the past 3 decades, given the endovascular treatment methods nowadays. And also, the most common indications for bypass nowadays is complex aneurysms. So meaning by complex aneurysms, we mean, we're talking about the perforating arteries or the wide neck aneurysms, thrombosed and atherosclerotic lumen. Those are very difficult to clip or coil. And the second most common indications for cerebral bypass is Moyamoya vasculopathy. So let's talk about the atherosclerotic disease indication. A famous study, the ECIC bypass study or trial that was conducted from 1977 to 1985, published in 1985. That study contained 1,377 patients that were both grouped into the medical only group and the medical plus bypass group. And the inclusion criteria was atherosclerosis in the MCA segment or the Petrus segment and above of the ICA. Unfortunately, this study had negative outcomes. So patients in the medical group had actually less stroke incidence than patients with the surgical plus medical group. However, this study had major criticism. It has observational bias. It cannot be generalized to the public. And the most important thing that this study was criticized for is the lack of hemodynamic measurements. And of course, at that time, there was not a lot of devices that measures the hemodynamic flow and oxygen extraction ratio. There's another study called JET1 study that also studied bypass versus medical group. And in this study, they also measured the oxygen extraction fraction. And they witnessed a reduced stroke incidence in the bypass group depending on the pre-op oxygen extraction fraction. Another famous study called the COST trial, which means or stands for the Carotid Occlusion Surgery Study Trial, it showed similar results between the medical and the bypass groups. So again, there's really no difference between both groups, even with the bypass and medical group combined together. Another trial called the RECON trial. So this RECON trial actually studied the cognitive improvement in the medical versus the surgical group, and again did not show any significant differences between both groups. Hence, cerebral bypass is not recommended for atherosclerotic disease unless there is a refractory ischemic symptoms. At that time, such bypass option may be entertained. And the level of evidence of this type of treatment is 1A, and the recommendation is A. So we have all these trials that did not show significant difference between the medical and the surgical / bypass group. It's worth mentioning that there are two ongoing trials. The ERSIAS trial, which is basically an indirect bypass trial in atherosclerotic disease, and the CMO-SS trial, which stands for the Carotid Middle Cerebral Artery Occlusion Study Surgery Study Trial. Still, we don't have any results yet. ERSIAS have preliminary results, but did not publish the entire data yet. So it's actually pretty interesting to follow these trials and see what they will conclude. Now, going to the second indication for cerebral bypass is Moyamoya vasculopathy. So by vasculopathy, we're talking about both Moyamoya syndrome and Moyamoya disease. And we all know that bypass decreases both ischemic and hemorrhagic complications in Moyamoya vasculopathy. Now, the ischemic Moyamoya bypass level of evidence is 4, and the recommendation is C, because of the very high annual ischemic stroke in these patients. Thus, there's no randomized controlled trial in ischemic Moyamoya bypass. Now, another famous study called the JAM trial, which stands for the Japanese Adult Moyamoya Trial, it showed significant reduction actually, in the hemorrhagic complication recurrence and also improved prognosis in a 4-year span. And thus, you can see that hemorrhagic Moyamoya bypass level of evidence is 1B and recommendation is A compared to the ischemic Moyamoya for bypass. Abla and colleagues have published a paper a couple of years ago that actually showed 71% reduction in symptomatic outcome and 87% reduction in the functional outcome of Moyamoya vasculopathy. And generally, symptoms resolve within 1 month of bypass in Moyamoya vasculopathy. This is a study that we published last month in the Stroke Journal. So we performed an updated systematic review and meta-analysis comparing direct, indirect, and combined bypasses. So just to briefly summarize this article, direct bypass has shown significantly less early ischemic complication compared to indirect bypass, And the combined bypass, which is direct and indirect bypass, have shown less early hemorrhagic complications than indirect bypass. Now, going to aneurysm, we just alluded to that a couple of minutes ago, that complex aneurysms who are not amenable for clipping or endovascular coiling are then can be bypassed. And direct bypass is required because we want to maintain flow and not augment flow. And the level of evidence is 4, and the recommendation is C in this case. And the other indication for cerebral bypass, which is skull-based tumors, and as Dr. Ivan mentioned in his lecture, for skull-based carcinoma, the more you resect, or the gross total resection that you achieve, the more favorable outcome or overall survival. So the general consensus for skull-based tumors that are invading or encasing blood vessels are more leaning towards partial resection with chemo and radiation. However, bypass can be an option if complete resection will improve survival and quality of life, especially in cases of carcinoma, skull-based carcinomas. Now, shifting gears to bypass techniques, we know that the choice of graft depends on the availability of donor vessels, the availability of interposition graft, the size of the recipient vessel, and the desired blood flow augmentation. Now, the direct bypasses can be categorized into an extracranial to intracranial bypass or an intracranial to intracranial bypass. The ECIC bypass can be either with grafts such as radial artery graft or saphenous vein graft, or it can be associated with no graft such as an STA to MCA bypass. The IC to IC bypass can be either with graft reimplantation, meaning that you would ligate a vessel and then you would transpose that vessel to an adjacent vessel to augment flow. In situ bypass, meaning side-to-side bypass, and re-anastomosis, such as in aneurysm cases where you ligate and resect the aneurysm, then you just re-anastomose both ends of the blood vessels in an end-to-end bypass. So blood flow type can be categorized into low flow bypass, which is less than 50 ml per minute, or high flow bypass, which can be 50 or above. This is a bit controversial because all of us who work with Dr. Morcos, we've seen that vessels with low flow bypass actually can be high flow bypass, can reach up to 90 ml per minute. So I added that since it's very common in the literature to mention both the low flow and the high flow bypasses. The interposition graft, which I've mentioned a minute ago, so they include both the radial artery graft, which carries between 50 to 150 ml per minute, and the saphenous vein graft, which carries 100 to 250 ml per minute, which is higher than the radial artery graft. The issue with radial artery graft is that it can have vasospasm, but it's usually the first desired graft, and then followed by a saphenous vein graft. Now, this is a figure that I obtained from one of Dr. Lawton's publications that summarizes the different anastomotic types in a very simple cartoon. So this figure here shows an end-to-end bypass where you join both ends of the vessels, and this shows an in situ bypass, aka side-to-side bypass, and then you would have an end-to-side bypass, either ECIC, which is the upper column, or the ICIC, or the intracranial to intracranial bypass. And this is the reimplantation that I've mentioned a minute ago, where you have to ligate a vessel and then you would reconnect it to an adjacent vessel to augment flow. Now, these figures are obtained from Dr. Lawton's 7 bypass book. It's a very important book that I highly recommend for those who are interested in bypass to obtain and read. So first, let's talk about the end-to-side bypass and how you would suture such bypass. So in this example, Dr. Lawton provided a pica, so a VA, meaning that vertebral artery to pica bypass using a radial artery graft. And this, he first started with suturing the foot of the radial artery graft, and then you would apply another suture on the heel of the graft. And once you tie both knots, then you would start from the foot of the bypass all the way to the heel of the bypass in running fashion. And then you would tie a knot at the heel of the second suture, and then you would flip the radial artery graft or whatever vessel graft that you obtained, and then you would start from the second suture all the way to the toe of the radial artery graft, and thus you would secure an end-to-side bypass. The second type of bypass is a side-to-side bypass. In this example, it's a pica-to-pica bypass. You would first start with a suture at the anterior portion of both picas, and then once you tie a knot at the anterior portion, you would then do a second suture at the posterior portion of both picas, and then you would go back to your first suture, and then you would start into inside the lumen of the vessel in a running fashion all the way to the end, and then you would exit to the extraluminal space, and then you would tie a knot at the posterior portion here. And once you tie a knot, then you would start with the external portion of the vessel in a running fashion all the way back to the anterior portion of the picas. And thus you would secure a pica-to-pica bypass. An end-to-end bypass. So in this example, it's a complex MC aneurysm, not amenable for clipping or coiling. So you would excise the aneurysm after you trap it, and then you would connect both ends in an end-to-end bypass. So you would start first at the 12 o'clock angle, and then once you tie a knot, then you would actually flip the graft to the right side, and then you would go all the way to the 6 o'clock aspect of the blood vessel. And then once you tie a knot there, then you would reflip it back to the left side, and then you would continue your continuous suture all the way to the 12 o'clock aspect of the blood vessel, and thus you would secure an end-to-end bypass, as shown here at the last figure. Now, this is another figure that actually shows two variations of an end-to-end bypass. You can either start with two sutures. One suture would go and connect the blood vessels endoluminally, or you would do it with one suture in a 360 fashion. So you would start in the 12 o'clock area, then you would go all the way to 6 o'clock, and then you would bury your suture deeper into the blood vessel, and then you would suture all the way back to the 12 o'clock area, and thus you would secure an end-to-end bypass. So this is actually a picture of a microscope that I have in my apartment. I just want to urge my co-residents and junior residents, whenever you're free, just purchase a microscope. And you would it's very easy to train on. You would have a Raytech or a synthetic blood vessel, and you would just suture micro threads of the Raytech as shown here. You can just do it 20 minutes a day. It's not going to take much of your time. And the more you do it, the more you're going to find yourself, faster, more accurate in your stitches. So I just highly recommend that for all residents to try back home. And I'm showing actually one of the cake pans here that I've learned from Dr. Bashkaya at the University of Wisconsin. So you would use this cake pan to elicit a deep bypass technique, especially when you do posterior circulation bypasses. It's not as easier as an ST8-MCA bypass. So it's a pretty simple idea that I've never heard about before, but honestly, it's really effective in eliciting deeper bypasses. So, this lecture is more about, the overview of bypasses. And here I'm actually done with my lecture, and I'm more than happy to answer any questions that you guys have. Any questions?
That was a great talk, Turki. And you know, I agree that the real challenge with bypasses is keeping your skills up, you know, since we're doing so less of them over time. So that's great that you're practicing. Yeah, nice talk.
Thank you.
Hey, Turkey, good stuff. How about talk to us about complications of bypass? How about hyperperfusion? What have you seen through your review of the literature? Some factors that perhaps explain hyperperfusion, and tell us what you know about that.
Yeah, absolutely. So this is very common, especially in atherosclerotic disease, where you have an ischemic part of the brain or a stroke in one part of the brain, that when you actually perform a bypass, you may cause hyperperfusion, hemorrhage in that area. So that's why, Dr. Morcos, you use the ultrasonic device to make sure that you do not exceed a certain threshold in the flow or the blood flow. I've seen sometimes that you actually had to bipolar some of the blood vessel wall just to decrease the flow to that segment to prevent hyperperfusion hemorrhage. So this is what I've seen so far and read so far.
All right. Sounds like this is it, Turkey. Thank you for reviewing this.
Thank you so much, Dr. Morcos. Thank you, everyone.